Good afternoon, Senator Jock and committee members. Thank you for the opportunity to testify in support of Senate Bills 343 and 300. My name is James Linn. I'm a board-certified OBGYN physician in my 40th year of practice in Wisconsin since completing my residency training. In addition to my private medical practice, I teach medical students and residents as an associate clinical professor of OBGYN. Most importantly, I've had the privilege of caring for thousands of pregnant women and their unborn children. I'm testifying on behalf of APLOG, the American Association of Pro-Life Obstetricians and Gynecologists. APLOG is a nearly 7,000 member organization of medical professionals who affirm the scientific fact that human life begins at conception and that the lives of mothers and their preborn children should be protected. As you know, after the Dobbs decision last year, Wisconsin's law prohibiting abortion except when the mother's life is at risk is back in effect. Since then, concerns have been raised about the law. No matter where you get your news, you've undoubtedly heard unsubstantiated claims that abortion restrictions in this law will cause women to die by preventing physicians from caring for life-threatening pregnancy complications. These include miscarriages, ectopic pregnancies, molar pregnancies, and other serious conditions that require the ending of a pregnancy early. I've encountered all these complications and can assure you that women don't die from any of these conditions due to abortion restrictions. The busy urban hospital where I work has always had policies restricting abortions essentially the same way the state law does. These restrictions allow the best care for pregnant women and their babies. I've never had a woman die or had to transfer a woman to another facility because of these restrictions. Based on my experience, I'm convinced that some people are deliberately making these specious claims hoping to overturn the state law. But I'm sure that other people have genuine concerns about the interpretation of the law. Therefore, I believe Bill 343 would be a good law to clarify those concerns. Some of the concern and confusion is a result of unclear terminology regarding the word abortion itself. The word abortion is commonly used in lay and legal language to refer to intentional killing of an unborn child. However, in medical terminology, abortion is any pregnancy that ends before 20 weeks. So medically speaking, a miscarriage is called a spontaneous abortion, and a miscarriage that has partially passed is called an incomplete abortion. The terms induced abortion or elective abortion refer to the intentional killing of the unborn child. SB 343 makes explicit that life-saving care of pregnancy complications is allowed in our state. Here are examples of pregnancy complications where SB 343 makes this explicit. Miscarriages. I care for women with miscarriages several times a month. Miscarriages occur in about 15% of all pregnancies. Many resolve on their own, but others require surgery or medication. The surgery commonly done for most miscarriages is a suction curettage, which is the same procedure used in most elective abortions. Even though 80 to 90% of OBGYNs in the United States don't do elective abortions, they all treat miscarriages with this surgical procedure. Medications like misoprostol are also sometimes used for miscarriages. These standard practices treating miscarriages are not elective abortions, and SB 343 clarifies that. Ectopic pregnancies. I treat several ectopic pregnancies every year. While less common than miscarriages, they're not rare. Ectopic pregnancies occur outside the uterus, usually in the fallopian tubes. They're dangerous because they can rupture and cause life-threatening internal hemorrhage. Treating ectopic pregnancies results in the unfortunate death of the embryo or fetus if it's still alive. But that's not the intent of the treatment, as it is in an elective abortion. Obviously, the intent of treating ectopics is to preserve the life of the mother. While the Wisconsin law has never been interpreted to prevent treatment of ectopic pregnancies, this bill makes it crystal clear that such treatment is not prohibited. Molar pregnancies. Molar pregnancies are genetic precancerous conditions of the placenta. They usually are treated surgically with a suction curettage. SB 343 makes it explicit that that treatment of molar pregnancies is also allowed. Early delivery to save the life of the mother. There are complications where the mother and the baby must be separated to save the mother's life. Examples include chorioamnionitis, an infection in the uterus, and early onset preeclampsia with severe features, a severe blood pressure disorder of pregnancies. If these complications occur before viability at about 22 weeks, delivery may be necessary to save the mother's life, even though it's too early for the baby to survive. SB 343 allows it if it's in the doctor's best judgment. Claims have also been made that restricting abortions will increase maternal deaths. This actually is not borne out by the evidence. For over 20 years, the U.S. maternal mortality rate has risen. Despite having among the least restrictive abortion laws in the world, the U.S. has a higher maternal mortality rate than most other similarly developed countries with more abortion restrictions. Studies from a diverse range of countries suggest that more abortion is actually associated with a higher maternal mortality rate, and that abortion restrictions may lead to improved maternal health. Poland, for example, has some of the most restrictive abortion laws in the world and also has the lowest maternal mortality rate. Up until recently, abortion was illegal in Ireland and Chile, except to save the life of the mother. Those two countries during that time had the lowest maternal mortality rates in their respective continents of Europe and South America. Now I'd like to speak in support of SB 300, and hopefully this will address some of the questions that were raised about it by some of the senators. The University of Wisconsin's OBGYN faculty and residents are state employees. And this bill prohibits them from being involved in abortion and abortion training. I anticipate opponents of SB 300 may make three false claims, which I would like to now refute. False claim number one: training in elective abortions is necessary to be a good OBGYN doctor. Opponents of SB 300 will likely claim that OBGYN residents at UW will be inadequately prepared if they cannot do elective abortions in training. This is simply not true. Residents in training learn the procedures to empty the uterus when caring for miscarriages and fetal deaths. The vast majority, 86% of OBGYNs in the United States, do not perform elective abortions. No OBGYN resident in the United States is required to do any elective abortions to graduate from their residency program. I've been board certified and recertified for 38 years and have never done an elective abortion. Obviously, it follows that the American Board of Obstetrics and Gynecology, which certifies qualified specialists in the field, agrees that elective abortion is not an essential part of being an OBGYN. False claim number two: the OBGYN residency program at UW will lose its accreditation if residents don't do elective abortions. It will be pointed out, and I think it has been pointed out today, that the Accreditation Council of Graduate Medical Education, ACGME, has a mandate that OBGYN residency programs provide abortion training as a standard part of their curriculum. That's true. They made that mandate in 1994 in an effort to promote abortion, but the mandate has not been enforced. It's unenforceable. Accreditation is not denied to programs that don't provide abortion training. In fact, a 2018 survey, which was published in the prestigious journal Obstetrics and Gynecology, surveyed program directors of all the accredited OBGYN residencies in the United States. And 36% reported that they were not in compliance with the mandate. None of them lost their accreditation. Why? Because federal law protects students, residents, and institutions from being forced to participate in abortion. Federal law also prohibits ACGME from denying accreditation to a residency that does not provide abortion training. While ACGME has this mandate, they can't enforce it. That would violate federal law, and they haven't enforced it. False claim number three: the University of Wisconsin OBGYN residency will have trouble attracting high-quality residents if it does not have elective abortion training. You may hear from strongly pro-choice faculty, residents, and students that they will leave the program if it doesn't provide abortion training. With all due respect, they will be replaced by prospective OBGYNs for whom abortion training is not a priority. These residencies are competitive. Not everybody who wants one gets into one. The vast majority of OBGYNs don't do elective abortions in their practice. Highly regarded OBGYN residencies will have no trouble filling their residency positions. In conclusion, elective abortion is always and intentionally takes the life of an innocent, unborn human being. That's a scientific fact. There's evidence that unrestricted abortion is associated with higher maternal mortality rates. Wisconsin law protects the lives of pregnant women and their children by prohibiting elective abortion. Please keep it that way and help get these bills passed. Thank you.